Good afternoon. It's my pleasure to be here and to present our clinical experience with another type of scaffold. I heard about the slip and prime. I'm mostly user Chondro Plus user, so I'll show our results. I'm from Lithuania, much involved in sports medicine. I'm a physician of our national basketball team since 2007, also working for Žalgiris basketball team. I attended 3 Olympic Games, World Championship and Europe Championship, so I'm treating professional athletes, and they also have the problems with the cartilage, so I will show our results a little bit. We started treating osteochondral defects with old artroscopic technique, and we have a lot of publications. Now we have 22 years results. None of the patients had total knee. We compared with microfractures, and Oates technique were really effective, but its limitation of the donor site mobility. Then we tried to combine with scaffold extremely large osteochondral defects. We were also successful. Also applied this technique to the children, but anyway we have the donor site mobility. And the main issue for us what to do just with cartilage layer defect, not osteochondral. I am talking not about osteochondral, but only cartilage defects. So this is the most challenge for us, and according to ICRS consensus, it's recommended to use AMIC technique for this special indication, and we started with another type of the scaffold, doing artroscopically. Our results show that the single lesion treatment is especially effective, also effective treating multiple lesions, but less effective compared to single ones. And since 2018 we started with Chondro Plus scaffold, because this scaffold is really attractive. It's not only from the collagen, but its composition with hydroxyapatite, which is really important for the connection with the bone. And we're treating this with Chondro Plus, just chondral defects, not osteochondral. And our goal when we started to avoid mini arthrotomy, which is not bad, but it was our goal, and to implant it only arthroscopically. So our all cases are arthroscopic ones so far. This is example, the trochlea we remove, we implant the scaffold, and we check the stability, and the scaffold we fix with the fibrin glue, and we allow full waist bearing without any limitations after this type of procedure. How to implant, the questions how we can implant. We have the magic instrument, just syringe, 5mm syringe, very cheap. We cut this part of the syringe, and we implant the scaffold through the syringe in the dry situation. We introduce the shaver, extract the water, implant the scaffold, adjust to the edge, fix with fibrin glue, and then we check the stability. And this avoids to fracture the scaffold when we implant. So the syringe really helps us to implant the scaffold very safely and to adjust to the defect. Okay, this is for the trochlea. Then we move to condyles. For the medial femoral condyle, we use the same syringe and the same technique, and with the piston we press the scaffold to the defect. When we adjust, we introduce a fibrin glue, then we remove a little bit the extra fibrin glue, and we try to do all range of motion and look if the scaffold is stable. Then we can be much more aggressive with our rehabilitation. What is interesting that in our cases, the single medial femoral condyle defect, we out of 50 patients now in 5 years, we find only in 2 patients. All other cases are mixed with medial meniscus osteoarthritis, other combinations and anterior cruciate ligament. So it is very difficult to do randomized control trial because of the matching of the patients. But anyway, this procedure is really. Then we saw with the thin ceramic instruments, they're really helpful. We have adjustment for the Chondra Plus, and we can, as we saw from the presenter, we can do the round and also to do in arthroscopic way, and even in the kissing lesions, we do not afraid to implant the Chondra Plus scaffold. Then we move to the lateral condyle, which is a little bit much more difficult, but anyway, it is possible. Here is lateral femoral condyle. We do the same technique with the syringe pistol. We introduce, we press the membrane, we adjust. We always use a fibrin glue. Maybe we will stop in the future, but so far, for better sleeping, it's we just do it. And also single lateral femoral condyle defect only in 1 out of 13 patients. All the defects were in combination with other. Then we move to multiple defects. We try to fill all defects as much as possible. And these multiple dominate. Most of cases are multiple. The single place defects are really rare. And we implant here, we see the lateral femoral condyle, and then if we need even these small defects, we combine. It is enough material to fill all these defects, and we combine, and we are really happy to do this in arthroscopic view. This is another example, lateral femoral condyle, quite big defect, and the trochlea. We implanted the trochlea, and here is MRI. As we see a little bit bone overgrow in the groove, but here we see that in the lateral part it's really more is really nice. I want to show one very interesting case. 62 years woman with osteoarthritis. We did osteotomy. Open mesh osteotomy. We find grade 1 osteoarthritis in the medial femoral condyle and also in the tibial condyle. After we debrided the damaged cartilage, we got quite large defect. We implanted together with the HTO. Here we see the preoperative MRI. We implanted Chondra Plus, but she got a problems. She got a stiff knee because of a really too slow rehabilitation. So after 3 years, we decided to remove the plate, and we checked the look, how looks the defect. So it's really hard bone. I had the name thin ceramica. This is ceramica, like ceramica, artificial joint, and we are really surprised. I expected it will be bone, but it is really good cartilage. But otherwise, clinically, she's not really happy because of the stiff knee. But anyway, the repair place is really good. Again, then we moved to revisions. Here, the 45 years old patients. 2 years ago, he got ACL reconstruction, but the graft failed, and he got the bone marrow edema in the medial femoral condyle and the cartilage defect in the medial femoral condyle. Here, the arthroscopic findings, not really big defect, but still defect, no ACL graft. We did ACL revision, and we implanted the Chondra Plus in the medial femoral condyle. And after 9 months, we did MRI. Here we see the repair tissue and the well-integrated ACL graft, and the patient is happy. Also, we are not afraid to implant in the tibial plateau, along with the meniscus fixation. And some pictures are out and videos. I'm sorry, and we have more complex cases. Here, the congenitus lateral subluxation and the de jure grade 3 dysplasia of the patellofemoral joint. This young lady was not happy, painful, with dislocation of the patella. We implanted chondroplas on the patella, TT transposition and the epithelial reconstruction. Okay, doesn't work. Okay, she is happy. And 4 years after, we did the same with the other knee, but I'm sorry, the video is not working. Okay, and our most important case, this is our professional basketball player. He is our national player, also playing for the Žalgiris, used to play in the EuroLeague and now. So when he got the injury on the lateral femoral condyle along with lateral meniscus, he was 21 years old. So right knee arthroscopy was did with lateral meniscus resection, and the stimulation of the knot seems big defect in the lateral femoral condyle. But after 6 months, he still was not able to play. We did MRI. We saw the defect, bone marrow edema, good alignment. And he was not happy, and I'm sorry, the video used to work. Here you should see how he does 4 years after the surgery. Okay, hope. Yes. Okay, you should see it. Can you try to show this video? Now 4 years after this revision operation. Okay. Can you go back one? To see this video enough, no need to score this patient, just to see this video enough. No need to Q score or IKDC score or MOCAF score. Okay, here it is. So he's our national basketball team player and top player in the Žalgiris 4 years after this revision operation. Okay, and I briefly show our just follow-up. Now we have 50 patients. This is preliminary study with only chondral lesions, I-series grade 3. There is new classification we try to accept, ABCD, with different etiologies, degenerative, post-traumatic, traumatic, with different joint places involved, medial, lateral femoral condyle, patella, trochlea, only 10 single, 40 patients with multiple, and with many associated procedures. So this is quite difficult to match the patients. And only 17 primary surgeries, 33 of them are revision surgery, and only arthroscopic approach, and all are fixed with fibrin glue. Not very young patients, and heterogeneous etiology, most medial and femoral condyle and the trochlea, and quite large defects. And IKDC subjectively, overall score is quite impressive, only almost 37 improvement after 2 years. If we look at subgroups, there is no statistical difference between medial, lateral femoral condyle, trochlea, patella, so more or less the same, but not enough patients to do this significant differences. And I will show just a little bit, because this is offshore session, okay? So we are brave to do this is humerus head. So we implanted chondroplas for the humerus head defect. We removed. This is the glenoid. This is the defect. Here we implanted the membrane. Now we positioned it and fixed with fibrin glue and checked the stability. And the patient really happy so far 3 years after the procedure. Another situation is glenoid with posterior instability. When we have posterior labrum tear, degenerative, we remove, we match, we implant the scaffold and fix with fibrin glue. These patients, because of the posterior instability and a little bit of retroversion of the glenoid, are less favorable, but anyway we can fix it, and we hope this is really helpful. And another option we already saw for the ankle, for the talus, for the medial, Even when we have cyst, we remove the cyst, we take the bone from the calcaneus, we fix the bone cyst in the talus here you see, then we implant the membrane and fix with fibrin glue and full range of motion, no need to do arthrotomy, we do it also artroscopically and we allow full weight bearing immediately after the second day. And our take-home message is that we can get significant improvement in these even difficult cases. We treat quite large lesions, only chondral lesions, not really young patients. Procedure is effective combining with other procedures, but we see that it is quite difficult to do only in our institution to do randomized controlled trial because heterogeneity of the patients and complexity of the pathologies and the procedures performed at the same time. But anyway, this is safe, chondro plus scaffold, and we are really happy having this possibility to use in Lithuania this type, and we continue our evaluation with every patient, and we collaborate with the Think Keramika in this. Thank you so much. And we are happy that ICRS registry in 3 months promised us to put Lithuanian language. I do not see the president of ICRS. I saw happy in the morning session, but we got promises with Yula that she will help us to put, and we will be able to follow every patient in Lithuania. Thank you for your attention. Yeah.
Because this is one of the
yes.
controversial issues.
Yes. Thank you so much. Yeah. I'm not sure. We stopped to do microfractures. We do nano drilling with special artrex. They have special nano of this we put on the shaver. So we are more happy. I stopped the microfractures because I noted that we break the subchondral bone. This is not good. Then when we follow with MRI, we see bone marrow edema. This is not good. So in this year, we will start to add the cells, the chondrocytes, to the chondro plus, and they tell that no need to do because you got not needed the cells, no need to do this. So in the future, we considering even to stop to do nano drilling and just to take. Yes. Yeah, if we have, I had here that the colleague likes slim, you like the prime, but it's okay. It's a difficult situation when we have osteochondral defect. Anyway, yeah, I take the bone, I fill until I'm able to put the chondroplus. I don't know. I love this scaffold. Not slim, but chondroplus. I fill as much bone as I can adjust to the level of the healthy cartilage. And at the moment, I'm really happy. We use OATS Artrex instruments to implant and to do press fit, and it works in our hands. Thank you.